Hi everyone, welcome to your revision lecture on infectious diseases. I'll be running it. My name's Sophie Khan, and I would like to give a huge shout out to Sage Allen, who ran this revision lecture last year. And I've taken a lot of her slides content and copied it over to this one. So this stuff here is what you think might be on the exam. It's all the infectious diseases listed in your matrix, but you'll also be tested on a few other things. And question types in the exams are often what is the most likely causative agent for this patient's presentation? And then the second question type is which antibiotic or medication should you prescribe for this patient given they're presenting a complaint? So today's lecture, I'll go through questions and some didactic teaching on the matrix conditions, but I'll also chuck in a few of these other things that have been examined in the past. So we'll start off with viruses. So some general principles, often care for viral infections is supportive only. DNA viruses, so herpes, varicella, HPV, they often become latent infections that reactivate. Note that a primary infection is usually more severe than a secondary infection. And relatively benign viruses can be very dangerous for immunocompromised patients, so including these ones. And lastly, PCR is generally the best investigation for a virus. So there are a few antivirals that it is good to know. The first ones are these ones here, so acyclovir, famciclovir, valacyclovir, used for herpes and varicella zoster. For varicella, you'd be using them for the immunosuppressed patients, and you can also use them for shingles. And then they're especially useful in HSV for encephalitis, but also for genital or oral herpes, and they can prevent recurrence. Ganciclovir is used for CMV. With flu treatment, usually you'd only treat them if your patient is pregnant or extremely unwell. Otherwise, if you're using an antiviral for the flu, it actually only decreases their illness by less than 1 day, so it's really not worth it. But if you are going to give it, it's much more effective the earlier you start it. So hopefully within 48 hours of your patient's symptoms developing. And then lastly, you've got Paxlovid for COVID, and there's a few criteria that means they can access it on the PBS. So first practice question, please pause and read. Noting this and this rash here. So this particular virus, which I haven't revealed yet, has a few different stages. So it starts off with maybe some persistent lymphadenopathy or asymptomatically. And then you get, immunosuppression, which might give you a hint. So you get recurrent infections, fungal, bacterial, viral. You can get weight loss. And then it gets worse. You get diarrhea, persistent infections, anemia. And then lastly, you have AIDS. I'm sure you've all guessed what it is now. And it has a 2 to 4 week incubation. It's HIV. So this is a little diagram of the development of the disease. So you start off with this acute HIV syndrome, which has just random flu-like symptoms. Then as your CD4 count drops, you go into some clinical latency. And then eventually your CD4 count becomes so low that around here you get often get infections that then cause death. So what actually happens with HIV? This probably won't be tested, but it's very interesting. So I'll just whiz through it. The HIV, this is its structure. So it's enveloped, and that sort of binds it with the host cell membrane. The capsid is emptied into the cell, and then it undergoes the RNA inside the HIV virus structure gets reverse transcribed and actually gets integrated into the host cell's DNA here, so that the host uses the DNA to start replicating more HIV viruses, and all the different proteins that go into HIV get assembled at step 6. And then they do what's called budding off the host cell. And in that process, the CD4 plus cell is actually destroyed. And that's what leads to that CD4 count declining over time. So as your CD4 count declines and you become more immunocompromised, you get a range of different, you're more likely to contract a range of different infections. So at the start, you'll just maybe have a fever or arthralgia in that really acute phase. And then you can get things like, I mean, this is Guillain-Barré you can get with any virus really. And then as you become more and more immunocompromised, you get AIDS-defining conditions such as Kaposi sarcoma, non-Hodgkin's lymphoma, all of these things here. This is the epidemiology, so really common in sub-Saharan Africa. Investigations, so you can do serology and ELISA rapid testing. You can also do combination antibody testing, which is almost 100% sensitive. You can do an HIV 1 or 2 antibody immunoassay, differentiation immunoassay. That's the confirmatory test. And that's the other thing they like to test is this test, what is the best screening test and what is the best test to actually confirm disease? So it's a good thing to know for each condition if you can. Once they've started on treatment, so the aim is to keep a CD4 count normal, so you'll be monitoring that and monitoring the actual HIV load through looking at the RNA. You also should monitor the risk factors for cardiovascular disease and for osteoporosis, and this is because the treatment is basically causes osteoporosis in your bones sometimes, and because of infection. And management wise, so I've just drawn this diagram to show you there's lots of different drugs that you can use to manage HIV, and the initial therapy you use 3 or more drugs, and they act on all different parts of the HIV life cycle, as you can see here. It improves morbidity and mortality regardless of the CD4 count, and often I didn't even talk about the risk factors, but one of the biggest risk factors, as we all know, is men who have sex with men, and I forgot to touch on. That's why they include things like this in the STEM to suggest that they've gone overseas for a business trip and had dangerous sexual, undergone dangerous sexual activity. And sometimes if their CD4 count is really well controlled, then it's okay, and their disease is well controlled, it's okay for them to continue to have sex and they're not at risk of passing on the disease. So, I haven't, yeah, there we go. So these are all the different types of antiretroviral therapy that you might want to use for HIV. And then again, monitoring the CD4 count, presenting exposure to opportunistic pathogens because obviously it's an immunodeficiency virus, and then manage their comorbidities too. Do you need to know specific drugs? Probably not. So pre-exposure prophylaxis and post-exposure prophylaxis. So pre-exposure prophylaxis is taken daily for those at risk of HIV infection. Post-exposure prophylaxis, so you should get tested 4 to 6 weeks post-exposure, and again 3 months after exposure if you're on post-exposure prophylaxis. And similar to initiating treatment, you're on a 2 or 3 drug regimen for 4 weeks. And these are some examples. And just out of interest, they're all nucleoside reverse transcriptase inhibitors. So, what is this? A homeless man with acquired immunodeficiency syndrome comes in with painful lesions. Examination reveals this. Well, I put the answer here. This is scabies, and that's just because immunosuppression. There are so many different AIDS-defining conditions that you can know things about. I think the ones highlighted are good to be able to sort of recognize maybe in a photo or as buzzwords. But these are some of the things that I had notes on as well throughout the year. Will they test you on these? I think probably not. So next practice question, please take a moment to read. Okay, so palpable crepitus, they're trying to tell you that this is gas gangrene, which is of course caused by Clostridium perfringens. Next question from 2017. Hi everyone, it's just me again. I'm just popping in because I just want to provide some extra context to this multiple choice question. So the options include these.
in which case the most likely answer is probably influenza, but you might also consider this patient perhaps has dengue or something along those lines.
But basically, it's influenza A is the most common one. B and C are very rare. It's a single-stranded RNA virus. It's obviously spread by respiratory droplets and on contaminated surfaces. Um, uh, you can do a rapid antigen test. You can do a PCR test, and you can do serological PCR. Um, Complications include these four things: so myositis, rhabdomyolysis, myocarditis, and encephalitis. And the management, as we spoke about before, is supportive. So you only treat it if your patient is pregnant or if they're really high risk or unwell. In these people, the earlier you start it, the better. Prevention, it's recommended that everyone is vaccinated annually and to avoid super contacts. This is something I think they sometimes like to test. So antigenic drift, if we just imagine a boat drifting on the lake, it's not going very far. There are random point mutations in the influenza A virus, which causes just minor changes in the antigenic structure, but it does not actually alter the subtype of the virus. And this causes epidemics, not pandemics. Whereas antigenic shift is like shifting a gear, which is quite a clunky, big movement. Um, and this is when it's really interesting when two viral subtypes infect the same cell and they actually exchange genetic segments to create entirely new subtypes. And that can cause widespread pandemics. This is the pathophys. I really don't think they will test you on this. This is just for completion. Another question from 2017. So most likely causative organism, Streptococcus pneumoniae, most common cause of pneumonia. And patchy lower lobe consolidation, classic symptoms of pneumonia. 2016. And also 2014. So this is just a reminder about IgM and IgG. So IgM goes up first and then IgG. EBV, also known as the kissing disease. And these are some tips to prevent the spread of Epstein-Barr virus or mononucleosis. It's spread through saliva mainly, but it's also spread through sexual intercourse. And interestingly, 90 to 95% of adults are actually seropositive worldwide. But again, it's that 15 to 24-year-old age group that is most likely to be in your question stem. So the main symptoms, you get especially lymph node swelling, but all of these can happen as well. And this is a summary of EBV. So the diagnosis is on monospot test. And you can do a blood test for Epstein-Barr virus as well. Throat culture and rapid antigen detection test. Okay. So there are heaps of complications that can happen as a result of Epstein-Barr virus in lots of different symptoms in your body. I think the main ones to know are lymphoma, splenic rupture, and thrombocytopenia. So splenic rupture is why you should recommend that your patients with Epstein-Barr virus do not exercise, do not do any contact sports after contracting Epstein-Barr virus. But these are some other ones that can happen. So are they good to know? Probably not. So another question from 2017. Most likely causative organism of a urinary tract infection is, of course, E. coli. And I haven't covered ETEC or EHEC in this presentation. All right, so this one I couldn't find any questions on from 2013 onwards. So I've just made up this stem. So he's returned from holiday to Vietnam 3 weeks ago. We'd like to know the diagnosis, investigation, and management plan. With these symptoms and the travel history and the time course, the most likely diagnosis is malaria. So malaria is transmitted by the Anopheles mosquito, and it transmits the Plasmodium parasite, and there's a few different forms of the Plasmodium parasite, or variations. This is where it occurs most commonly, so around the equator. And we know as global warming increases and mosquitoes spread further this way and this way, if the temperature increases, that area is likely to increase as well. So the life cycle of the Plasmodium parasites is very interesting. So it starts off when the mosquito bites the human and causes sporozoites to enter into the circulation and pass into the liver. Um, Within the hepatocytes is where they develop, and then they release what's called merozoites. And in Plasmodium vivax and Plasmodium ovale, which are two subtypes of the Plasmodium parasite, some remain in the liver as a latent infection. So after the merozoites are released, they enter the red blood cells and they pass through several stages of development, and then which results in multiple merozoites. Once that happens, the red blood cell actually ruptures and releases the merozoites into the circulation, and then they can infect other red blood cells. A few of the merozoites in the red blood cells develop into gametocytes, so like gametes. And then when the next mosquito comes and bites the human, it allows the gametocytes to transfer to the stomach of the mosquito, where fertilization occurs, forming sporozoites, which migrate to the salivary glands of the mosquito, and then the whole cycle starts again. This is it simplified. So it goes into the liver cells, explodes liver cells, into the bloodstream, explodes red blood cells, into the mozzie, sexual reproduction, etc., etc. And this is just a visual summary of that as well, with some more specific stages, which you probably don't need to know. So you'll notice that there was a greater than 10-day onset in this question stem, which will become useful later in the presentation. The investigation, you should do a blood smear, a thick and thin film. There are rapid diagnostic tests, which is interesting, and I didn't know this, but you put the blood in here. It's like a COVID test, but with blood. And people with sickle cell anemia are partially resistant because when the malaria enters the red blood cell, it's less able to replicate for whatever reason. And then people with hemoglobinopathies also have partial resistance, I imagine, for similar reason. So, treatment. These are the treatment options. So for uncomplicated, you can prescribe any of these combinations, as far as I have learnt. And then if severe, get expert advice, and you can do similar therapy but IV. Prevention is key in malaria, so avoiding mosquito bites in the first place, using nets, repellents, insecticides, like long clothing, things like that. You can also take prophylaxis. This doesn't actually prevent the malaria infection, it just delays the onset so that you can get back to the country to be treated before it gets bad. So they use these combinations, so atovaquone, Proguanil, doxycycline, mefloquine. Complications of malaria, I don't think they'll test you on, but if you would like an acronym, you can use malaria for these things. So metabolic acidosis, anemia, which makes sense because of the red blood cells. Lungs, you can get pulmonary edema, altered consciousness, reduced glucose, infant death, and acute renal failure, which makes sense if you think about them, but we won't go into them. So next question. So a man who has had antibiotics and now has diarrhea has Clostridium difficile. Next question. Again, I couldn't find any questions on this. Is a matrix condition. I couldn't find any questions on it since 2013. So we have made up a stem. So this person has returned from Indonesia only 1 week ago, as opposed to our guy who returned 3 weeks ago in the last stem. Fever, unwell, a rash, lymphadenopathy. She's got some hemorrhagic manifestations of this particular disease, including petechiae, but she doesn't have any evidence of circulatory collapse. So she doesn't have the shock syndrome of this disease, which is, well, not yet. So on examination, you perform the tourniquet test, which is this little thing where you take the patient's blood pressure You record it, you inflate the cuff to a point midway between the systolic and diastolic pressures, and you maintain it for 5 minutes. And then you reduce the blood pressure cuff, you wait 2 minutes, and you count the petechiae below the antecubital fossa. And I think it's above, I'll have to double check, but it's some number of petechiae per area that's a problem. Thrombocytopenia, liver enzymes elevated. Serology, PCR, and ELISA are the tests of choice for this particular disease. You also get a viral nucleic acid and antigens and confirm that the diagnosis is dengue. So dengue, a less than 10-day onset usually. It's transmitted by the Aedes aegypti or Aedes mosquito, and the actual organism is flavivirus, which is an RNA virus. So our patient presented with this break bone fever primarily, but she also had some symptoms of hemorrhagic fever with those petechiae in the antecubital fossa. She didn't have any symptoms of dengue shock syndrome, which is just a circulatory collapse. So you measure that with pulse, hypertension, clammy cold. Differentials for dengue, Zika, Ebola, yellow fever, malaria, and typhoid. So again, this is one of the differentiating things between malaria and dengue is the time of onset. This is its distribution. So mosquito born again, it's sort of located around the equator. Dengue treatment and prevention. So for treatments, in non-severe illness, you give paracetamol, but not NSAIDs, and that's because NSAIDs carry a, fill in the blank, high bleeding risk, and in a disease with hemorrhagic manifestations, you don't want to increase that. If there's severe plasma leakage, you can top up their IV fluids. So prevention, again, avoid mosquito bites in the first place. Vaccination with dengue is interesting in that it's only beneficial if you have previously been infected. A question from the 2015 exam. Going off the beaten path, eating where the locals eat. This man, if you had okay, this is pretty undifferentiated and there are actually a few options for this man could have, but if we had put the options up, you would maybe know that this would be Giardia. But valid differentials, which hopefully won't be on the multiple choice, include Entamoeba histolytica, Shigella, Campylobacter, and Salmonella, all sort of present with this sort of picture, but probably most likely is Giardia. Okay, a question from the 2015 exam. Okay, this constipation is interesting. A question from the 2016 exam on the same organism. And this one has loose watery bowel actions. And then the 2014 exam actually had a repeat of the 2015 exam question. And the answer is Salmonella. So Salmonella is interesting in that it can actually cause, in the second week of infection, it can cause constipation or diarrhea. And they call it pea soup diarrhea, and it looks a bit like this, which is off-putting. It's got a 5 to 21 day onset, and it's transmitted in contaminated food and water. So the first week you just get sort of generic symptoms, fever, chills, bradycardia. The second week is when you get some more specific signs, so this rose spot rash, this diarrhea, or constipation. And then the third week is when it gets really bad, and you can get hepatosplenomegaly, intestinal bleeding, and confusion. And salmonella actually used to be really dangerous, and greater than 1 in 5 people died when they got salmonella, but now it's down to 1% to 4% with treatment. And here's a little infographic for the visual learners. So you diagnose salmonella with a blood culture and a stool culture, and you should do sensitivity testing because there are high levels of resistant salmonella. You treat with azithromycin or ceftriaxone. And to prevent the spread of salmonella, you should engage in food and water safety. So cleaning food, cleaning hands. There are some vaccines available, but the efficacy varies and it sort of depends on travel planning. So it's sort of travel medicine specific. And this is where you can find outbreaks of salmonella mainly. So again, I didn't find any questions on this matrix condition from any exam since 2013. So I've made up this stem. 3 stems, in fact. So this first one, it's actually quite hard. I don't think they'll test you on this like this. Um, all of these are the same organism or pathogen, and that is, oh yes. So the first is talking about esophagitis, the second one is talking about mononucleosis, and the third is talking about retinitis, but they're all caused by CMV. So CMV, if you're infected, 90% of people are actually asymptomatic, and you only really get symptoms if you are severely immunocompromised. 10% of people with CMV get this mononucleosis, which presents like EBV, like in this diagram. So you get those swollen lymph nodes. Interestingly, CMV establishes a latent infection after the acute infection, and it cannot be cured, but it's often asymptomatic. So again, many people are seropositive for CMV. It's easily transmitted through sexual contact, close contact, and in pregnancy. It is dangerous. And about 50% of people have been infected in Australia. So in the immunocompromised, it can cause so many different presentations. These are the 3 stems that we have looked at, but it can also cause pneumonia, encephalitis, adrenal insufficiency, and everything can cause Guillain-Barré syndrome. To investigate for CMV, you can rule out EBV by doing a monospot test. The blood smear will show large atypical lymphocytes with Ring-Sternberg-like cells. You can do serology and look at the IgM and IgG. You can do nucleic acid amplification testing, and ELISA and PCR. Your FE will show lymphocytosis, and you can look in the back of the eye with a fundoscope and observe for retinal hemorrhage and cotton wool spots if you've got CMV retinitis. The treatment, as we mentioned earlier in the presentation, is ganciclovir. So next question, 2017 exam. University student. Severe headache, bilitis headache. Okay. Non-blanching petechial rash, all very characteristic of meningitis, which is actually on the neurology matrix, so we will not cover it today. Next question. Diffusely inflamed lower leg with a superficial abscess. We have to think about cellulitis, which means the most likely causative organism will be our favorite Staphylococcus aureus. If in doubt, answer Staphylococcus aureus. Okay, this condition is a non-matrix condition, but it appeared twice in 2013, 3 times in 2014, once in 2015, once in 2017, and they really like testing for it. And examples of the stems that they might give you include the following on your screen. Night sweats, weight loss, spitting blood, lethargy, productive cough, a Chinese student, Indian-born man. Yes, what do you know? It says pulmonary tuberculosis here. That's very helpful. As you can see, they sometimes double up their question stems. And sometimes they'll ask you about the management. So this is tuberculosis. Essentially, they'll give you a stem which looks like lung cancer with some sort of travel history. You should do a chest x-ray. You should also do a sputum sample and look for acid-fast bacilli via a smear. You can do a mycobacterial culture, and you can do nucleic acid amplification testing. You can also do this Mantoux test and the tuberculin skin test for diagnosis. In terms of treatment, the first phase of treatment is 2 months of all of the ripe drugs which you have learnt. So rifampicin, arsenizid, pyrazinamide, and ethambutol. And then you do 4 to 7 months of just the R and the R and the I drugs. So, next question. So this man has pneumonia. What is the most common cause of pneumonia? I think we have two options. We've got Klebsiella and we've got staphylococcal pneumonia. Um, by far the most common cause of pneumonia is staph pneumonia pathogen. So we would go staph pneumonia. Um, Things that have been options in multiple choice questions that I have not covered in question stems include the following, if you would like to look into these further. I'm not sure if they will test you on them or not, but it's probably good to know a couple of buzzwords and have a general clinical picture in your head of how these might present. So, antibiotics. Before we talk about antibiotics, we'll just recap where different sort of organisms live in your body. So first, gram-positive organisms, you can find them on your skin in the form of staph or strep. You can find them in your gut in the form of enterococci, and you can find strep in your ears and throat, lungs, and in meningitis. Gram-negative organisms, gut and hopefully not urine for E. coli. Pseudomonas, Neisseria, Haemophilus influenzae, and then anaerobes, so Clostridium, and some other gut bugs too. So general guidelines: if you have a staph infection, you should give flucloxacillin, and if your staph is methicillin resistant, you should give vancomycin. For Streptococcus, if you want to give an oral form of treatment, you can give phenoxymethylpenicillin. If you want to give an intramuscular form of treatment, you can give benzathine penicillin. And if you want to give IV antibiotics for a strep infection, you can give benzyl penicillin. For mild gram-negative bacilli infections, so in a UTI, you would treat with trimethoprim and otherwise with cefazolin. If you have a serious gram-negative infection, you can do broad coverage treatment via gentamicin or ceftriaxone. If you have an anaerobe, metronidazole, especially for GIT bugs. But in skin, you can use clindamycin, and if they're intracellular, you can use oral doxycycline or azithromycin. We've talked about that. Augmentin is amoxicillin plus clavulanate acid, which just increases the efficacy of the amoxicillin. And if severe gram-negative infection, you give gentamicin. So if you have not identified the organism for a GI infection, for example, sometimes you would just give metronidazole and ceftriaxone to cover most of the possible causative organisms. And this is a fantastic diagram, which I have only recently discovered, which you should not memorize, but you should reference and understand, I suppose. So it starts off with what you should use for more mild infections and then goes all the way down to really hardcore antibiotics. So, for example, you can see if you've got a strep infection here, you'd start off with a penicillin, and then if that's not working, you can go up to a cefazolin. You can even go up to meropenem here. Anyway, this is just a really good chart that I thought I would show you, and you can use as you wish. Sometimes you haven't identified the organism as yet, but you know what condition your patient has, and so you can treat them empirically based on the probable causative organism for their presentation. So, for example, infective endocarditis could be caused by lots of different organisms, and so we treat with these benzyl penicillin, fluclox, and gens to cover all of these organisms. You should definitely know this pneumonia treatment, the pneumonia treatment formula. So for mild, you should use Amox. For moderate, you should use Ben, Pen, and Doxy. And for severe, you should use ceftriaxone and amoxicillin. Hospital acquired is a bit different, but you definitely need to know this one, and it's useful to know this one. TB, you should definitely know all the drugs. That's fine. We've already talked about that. 2 months of RIPE, 4 to 7 months of R&I, rifampicin and isoniazid. This is interesting. So they used to use Gent, metronidazole, and amoxicillin for gut infections, but they now use Gent and ceftriaxone. So you might have to double check that one. Etc. So now for a multiple choice question. So this 80-year-old man has been in hospital with pneumonia, and after 10 days he has developed diarrhea. So remember, antibiotics plus diarrhea equals C. diff. If we go to the next slide, we can see that C. diff is an anaerobe. And if we go back, we can see that we want to treat our anaerobes with metronidazole, especially if they're in our gut. So we're going to treat with metronidazole. And I've got the slides here. Fantastic. Next question. This man has a productive cough, 402 sats. He's got consolidation in his left lower lobe. He's got multiple gram-positive diplococci, so we think he has strep. I'm just giving you the answer. We think he has strep, so we're going to treat him with one of these treatment options. And we're going to choose benzyl penicillin because that is the best option out of our multiple choice questions. Multiple choice options. Next question. Okay, you've got back pain, you've got a blood culture growing gram-positive coccus in clusters. So you're thinking you have a staph infection, gram-positive coccus, and therefore you're going to treat with Fluclox. Okay, we haven't asked any questions about when to treat with amox, ceftriaxone, clotrimazole, doxy, ketoconazole, or any of these ones. So I recommend you look up. We've talked a little about trimethoprim and ceftriaxone and amoxicillin. But be familiar with what you might want to use these for, which you can just look at this tape.